Can you hear me okay? So I did not graduate from Mizzou, and I'm actually an alum of 4 months, so probably the most junior alum here. And I'm going to be talking on schizophrenia, which is something I've spent my career studying, treating, worrying about. But I also am going to tell you a little bit about where the department is, even just 4 months into my tenure. And we'll talk a little bit about, because there's been some really radical changes, I would say, in the department. And I think you might be curious, especially if you trained here, to see what's changing. And I have to do this all in about 45 minutes. So at some point, I'm going to start talking really, really fast. But you'll see when that happens. And so I'll break the talk up into kind of 3 parts. The main part will be just to kind of give you an update on schizophrenia as it's seen today. And it's changed slightly over the years, but and more emphasis on certain other kinds of symptoms than what you might have learned in medical school. So I'll give you a crash course in schizophrenia. We'll talk about something that I'm about to be working on in a presentation. I thought, well, what should I talk about? At first I started saying, oh God, I got to give this talk, what should I talk about? And then I reached a point where I said, what should I not talk about? Because there's so much to talk about when you, in this area. But I want to talk about a new approach maybe to schizophrenia that we're going to potentially do here and around the country. And then finally tell you a little bit about the department. So let's first start with just grounding you into how significant is schizophrenia. Well, it affects 1% of the population. So that's about 3 million people. And it's a disease that really, what I used to call, robs people of their, it's a disease of lost opportunities. Because you can have a kid and he can be looking fairly normal all the way up to age 18. And then boom, he's hit with this illness. So you had all these hopes for him to go to college, to get a job, to do all these things, and then all of that is really radically changed. That isn't saying that people with schizophrenia cannot complete college, because they can. It doesn't say they can't have a job or get married, but they can. But I would say that the vast majority have a tremendous change in what ends up happening in sort of their trajectory of their life. Tends to happen to men younger than women, and that's not good. This is an illness where the later you get it, the better. The more skills you can develop, the more, if you can get married, all those things really do help your long-term prognosis. It's an incurable illness at this point. I mean, we can control a lot of the symptoms, but it's essentially incurable. It has a high relapse rate. And then one of the things that's really become to the forefront, and actually Missouri has been a leader in this with Joe Parks from the state, it has a very high mortality rate. And this mortality, so the average person with schizophrenia lives about 20 to 25 years shorter than you and I. And this has great implications. There are lots of reasons. Cardiac disease is probably the #1 reason that they pass away. What I've seen, even in the 20 years that I've been working in schizophrenia, as we have gotten older, we're actually pulling people with schizophrenia with us. So in some ways, when I started, there weren't a lot of 60-year-olds with schizophrenia, and now there are. They're still dying 20 to 25 years earlier than the rest of us, but we are now dealing with elderly patients with schizophrenia in a way we never did before. And so what is this illness? We often call it a complex disorder. That means that there isn't a simple causation, and there isn't even a simple symptom cluster. People can have a little bit of a lot of different things. And here I sort of have organized this in terms of what we would normally say is the positive symptoms. These are the things you see in the movies and you probably know more about, which is the hearing voices, being paranoid. But it turns out that likewise, people with schizophrenia have a major change in their affect, their ability to feel things, to enjoy things, their drive, their motivation, their sociality. If you talk to people's parents, they often will say, well, we know he has this, but you know, he never gets out of bed, or she never wants to do anything. That's the thing that really gets the families often, is that really this sense of negativity that comes with the illness. And then, of course, over the last few years, we really see that people with schizophrenia have cognitive problems. You may have heard the term dementia precox that Kraepelin first introduced in the early 1900s. People with schizophrenia do not have a precocious dementia. They are not demented. What they have instead is a wide range of cognitive problems that are clearly noticeable on testing, but even noticeable sometimes when you try to interact with them. And then, of course, mood symptoms come, patients with schizophrenia can be very flat and blunted and not have a lot of emotion, but they can also be very dysphoric and suicidal. So it's really a panoply of different kinds of symptoms. But the bottom line is all of these symptoms affect functioning. So I always say I'd rather have a paranoid person with a job than someone with schizophrenia who isn't paranoid but just lays in bed all the time. So what we really are trying to get to is to get people to function, because the reality is without doing things, without going to school, without having friends, without having a job, your life is pretty meaningless. So the goal is not to eradicate every psychotic symptom that the person has. The goal is to get them to function at the highest level possible. So what causes schizophrenia? We don't entirely know. But we know a lot more over the last 50 years than we ever did before. And nice to say, for the first time, someone with a psychiatrist studying schizophrenia won the Nobel Prize in the year 2000, Arvid Carlson, to basically promulgating this dopaminergic pathways, dopamine hypothesis of schizophrenia. And what it essentially says is that there's dopamine in the brain. And that dopamine does a lot of different things. It helps with reward, it helps with smooth movement, and it really has an association with whether people have these psychotic symptoms. And these symptoms can be traced to these tracts that occur in the brain, these primary tracts that have dopamine receptors. And this big one, the mesocortical tract, this really has a lot to do with attention and cognition. This nigrostriatal tract, that's the tract that has to do with whether someone looks like they have Parkinson's or not. This mesolimbic tract, which is in the temporal area, is associated with the hearing of the voices. This tuberoinfundibular tract with the endocrine problems one would have if one blocked dopamine. So one of the interesting things is that probably there's an aberration in all these different areas. The other challenge is that when we give medications to treat this, the medication is not selective to the particular tracts. So it's going to bind onto everything. So we might get someone to be less psychotic, but we also might make them extremely stiff. And the reason is that these tracts, the drug doesn't know where to go. It goes wherever there are receptors. But the other thing that's been kind of hot in our field right now is the contribution of glutamate to the whole concept of schizophrenia. And there's a very complicated interaction between glutamate and dopamine. But the simplest way I like to think about it, because I tend to think more in the cartoon realm, is that when a person is first ill, they probably have hyperglutamatergic functioning in their brain. In some ways, the glutamate the gas is on really high for a long time. And over time, that burns out the system. And by the time they're diagnosed with schizophrenia, they will have a tendency to have low glutamate. And why is that important? Well, it turns out that glutamate is really associated with cognitive and social function. So one of the exciting things in our field is that pharma is now developing drugs that modulate glutamate. So for as long as I can remember, every drug that has really treated schizophrenia, and we'll talk about treatment in a second, has been a dopamine blocking agent. But now, for the first time, there is a chance that there may be some agents that we can use that can treat schizophrenia or parts of schizophrenia without directly blocking dopamine.